And we are live, Senators.
All right, good morning. This is Senate Health and Welfare. It is Thursday, April 6th, and we're going to be looking at a couple of bills, H-171 as well as H-222. And we have Representative Noyes here, reporter. So thanks for being here. Why don't you introduce yourself for the record, and then we get like sort of the quick overview of what the bill.
Of course.
Yeah.
So good morning, I'm Dan Noyes. I'm the representative for Wolcott, Hyde Park, Johnson, and Belvedere. Serve on the Human Services Committee. So H-171 updates the statutes that protects vulnerable Vermonters whose health and welfare has been affected through abuse, neglect, or exploitation. These laws were originally developed in 1979, and they've been updated over a couple of times over the years. But a lot's changed with individuals now choosing where and from whom they can receive care from. The original statute, victims had no review or appeal rights. In fact, alleged perpetrators and even reporters were afforded more rights than the victims. So when this statute was originally passed, many vulnerable Vermonters, including individuals with disabilities, lived and received care in institutional settings. Nursing homes and residential care facilities are still an important part of the continuum of care, but now people are choosing to receive their care in their homes and communities from a spouse, family member, loved one, or person of their choosing. And it's important that the laws reflect that change in care. So just some background that I'm sure you'll hear from APS when they're up here, but they received around 3,600 calls, had 876 investigations, and 41 people were put on the Adult Protective Service Registry. So that registry is checked by people who are running volunteer programs, and employers to find out if a potential volunteer or employee is listed on there. And it was checked 64,000 times last year. So it definitely gets some checks through background checks. Many agencies rely on this for their background checks, so it's important that it's reflects individuals who we should make sure are not providing services. So you'll hear, getting a walkthrough for the bill. I'm not glad to do it, but I think you have someone who knows much more about it. So there's two key factors to be considered before an investigation can commence, and that is the individual a vulnerable adult, and is there allegation of abuse, neglect, or exploitation? So without both of those, there's no investigation by Adult Protective Services. If there is a neglect or exploitation is alleged, then this legislation creates two tracks. One is an assessment, which leads to greater flexibility of reducing harm through proactive measures of reparations and rehabilitation. And the other is a full investigation that could lead to placement on the Adult Abuse Registry and the involvement of law enforcement and criminal charges. So the reason that there's two is because if people are receiving care from a spouse or a loved one who's their care provider, they're not looking to go into this business. They're not working at an institution. They're providing care to someone who lives with them. And so if there was a way for us to try to figure out how to stop anything that's happening and make sure that they're still able to receive the care, then we should take advantage of that. However, there's always the option to put that individual into a full investigation that would result in, like I said, it could even result in criminal charges. But so kind of the overview of the bill. And one thing that I'll just point out that last year, or no, it's been 2 years now, we passed the Older Vermonters Act. And it really set some principles of system of services, supports, and protections for older Vermonters in this legislation. It was Act 156. This legislation holds self-determination, safety, and protections as paramount and acts and the act states that older Vermonters should be able to direct their own lives. Whatever services, supports, and protections are offered, older Vermonters deserve dignity and respect and must be at the core of all decisions affecting their lives, with an opportunity to accept or refuse any offering. So in this legislation, we really thought about that, the Older Vermonters Act, and kind of how that legislation would play into this bill. Glad to answer any questions on how we got to where we are.
Two quick questions.
Yeah.
One, how did it go through your committee? What was the vote? And then the vote on the floor?
Yeah, so the vote on the floor was a voice vote, and there was no nays. In our committee, we had one no, and I think there was one person absent. So it was 9-1-1.
Okay, that's all. Okay. Questions? Go ahead.
Did they say the reason why?
No.
Are there problematic areas that we'll hear about them if they are, but
Yeah,
is there anything you can identify for?
not that I know. I'm not. I could find out.
We'll find, I'm sure we'll find out.
Why that person?
Okay. Anything else for Representative Moyes? Thank you.
Well, thanks for having me.
Thanks for your work on this. I know you've been engaged with us. We've been working on this for older Vermonters for a while.
Yes.
Your leadership in the area is really
Thank you.
important.
All right, thanks. All right.
So Katie, I have a feeling it's going to be the section by section.
Yeah.
Yeah, it's a long bill.
It's a long bill.
Good morning.
And in some ways, is it a sort of the technical corrections or cleanup to modernize? How would you describe it?
I wouldn't call it technical corrections.
No.
I should say Katie McQuinn, Office of Legislative Counsel. So the bill itself, let's see, the House version came in at 58 pages. I do have the section by section summary. Our first walkthrough in Human Services was the section by section summary, and it seems like that worked well because the bill itself is pretty dense, and it's nice to kind of get that. Not that the section by section isn't also dense, but I think that gives you more of a high level overview of what you're looking at. I would not call it technical corrections. I would say it's more substantive than technical
Policy
corrections.
decisions based
They're
on.
policy decisions. There's a section on definitions, and I couldn't tell you how many pages, maybe 15 to 20 pages on definitions. The section by section kind of glosses over that, but the definitions are very important, I think, in this draft because it defines who is a vulnerable person, what is abuse, what is neglect, what is exploitation. Those are some fairly important definitions when you're putting together a program to protect individuals. So I'll share my screen and we can jump in.
Okay, that's terrific.
Okay.
And if anyone wants a copy of anything, we have the section by section summary, and we also have the bill as passed by the House. So if you like,
I've got printed copies on their way for everybody.
that's good.
There it is. Get rid of that. There we go. Okay. So we're amending two subchapters in chapter 69. The first subchapter is on reports of abuse of vulnerable adults. And our first section is a purpose section. So the purpose is to protect vulnerable adults whose health and welfare may be adversely affected through abuse, neglect, or exploitation. To recognize and accommodate barriers for vulnerable adults that may impair both their response to maltreatment and their ability to substantiate allegations of maltreatment. Should say in the bill, the word maltreatment is defined to include abuse, neglect, and exploitation. So when we say maltreatment, it has a specific meaning of those three categories. The purpose is to require reporting of suspected abuse, neglect, and exploitation, investigation of reports, and establishment of protective services. It removes existing language pertaining to finding a nurturing and safe environment for vulnerable adults and intervening in family or substitute care situations only when necessary. And it adds language that aims to uphold autonomy and provide opportunities for consideration of vulnerable adults' preferences. Then we move to the definitions. As I said, this overview very much glosses over all the definitions. At some point, it'd be worthwhile just to spend a morning or an hour going through the definition section. We're adding a number of definitions. The definition section was, or currently is, I don't know, not short, but fairly straightforward. So this adds a number of definitions. Section 6903 pertains to the reporting of suspected abuse, neglect, and exploitation of vulnerable adults. So this section streamlines the list of mandatory reporters to all employees, contractors, volunteers, or grantees who directly provide healthcare, law enforcement, caregiving, counseling, education, or social services to adults who know of or have reason to suspect abuse, neglect, or exploitation of a vulnerable adult.
Does it make them mandatory reporters?
I believe so, yes.
And are they all currently mandatory reporters, or are we adding anything here?
To look at the language itself. So we currently have a list of mandatory reporters. It's more extensive. Talks about school teachers, school librarians, school administrators, guidance counselor. It has a very physician, osteopath, chiropractor. So this dentist, psychologist. So this streamlines it to have categories instead of
Only these
the
for
specifics.
vulnerable adults,
Excuse me.
but these are specifically identified.
For both, yeah, in the vulnerable adult chapter, yes. The nature and content of a report, to whom is a report made. So the language specifies that the report is made to the commissioner or designee. It removes language that the report can be made to a law enforcement officer. There's new language specifying that a reporter in possession of documentation establishing the alleged victim's conditions, needs, or services include that information in the report, as well as evidence of maltreatment. And then we get to the assessment and investigation. So the concept of the investment assessment track is a new concept that's added in here. Previously, this only pertained to an investigation section. So now there is this assessment track. An assessment can lead to an investigation, but an assessment does not have to initiate an investigation process. So they're sort of two separate tracks. They're not mutually exclusive necessarily, but there is an avenue in which an assessment leads into an investigation. So first, the report. Upon receipt of the report of maltreatment, Dale determines whether it constitutes an allegation of abuse, neglect, or exploitation. Dale must respond to reports about conduct occurring in state or conduct occurring out of state if the vulnerable adult is a resident of Vermont. If Vermont is accepted, if the report is accepted as a report of abuse, neglect, or exploitation, Dale determines whether to conduct an assessment or investigation or whether to screen out the report. An assessment may be used to determine whether an investigation is necessary. So that could be a precursor step to an investigation if the department isn't sure if an investigation is necessary.
Can you give me an example of why they?
I'll let them give you an example of why they're screened out. Yeah,
Thank you.
good question.
So it seems like there's already 3 levels here of analysis. One is whether it constitutes an allegation
Mhm.
Then if there's, then an assessment is made, and then potentially an investigation is made. Is that kind of like the flow path?
Yes and no. So I think the initial questions are, was this abuse, neglect, or exploitation? Is this a vulnerable adult in question? I think those are the two precursors. I think if it's pretty clear that the answer is yes to those questions, then the department is likely to move into the investigation. If more information is needed, probably an assessment would be conducted to gather that information before deciding that an investigation is necessary.
So the assessment isn't binding, it's just like a preliminary fact finding.
It's, yeah, more fact finding to determine if the report needs to be closed out, if it isn't actually a vulnerable adult in question, or this actually isn't neglect, or now that we have more information, we can move into our investigation stage.
Thank you.
Okay, top of page 2. If Dale initiates an assessment or investigation, it shall be within 1 business day after receipt of accepted report involving serious injury, hospitalization, sexual abuse, or ongoing harm, or 2 business days after receipt of accepted report in all other cases. So in certain circumstances, a faster response is required. Determination to conduct an assessment shall include consideration of the severity of alleged maltreatment and injuries, the relationship between the alleged victim and the alleged perpetrator, and the known history of the report. And it should detail and specify information in the report on the alleged victim's vulnerability and the alleged maltreatment. Dale is to investigate an accepted report involving allegations of serious maltreatment or ongoing risk of harm, and may investigate any report of maltreatment that APS receives, APS being Adult Protective Services. Dale is to immediately begin an investigation if at any time during an assessment an investigation is deemed appropriate. And to the extent permitted by law, Dale may collaborate with law enforcement, healthcare, and service providers, other Vermont agencies, and agencies in other jurisdictions to evaluate the risk to a vulnerable adult. And Dale may enter into reciprocal agreements to have those relationships to do their work.
Probably jumping way ahead, but does Dale have the capability? Do they do this now?
This is an existing program.
Oh,
So the program itself is at least 50 years old. And I think the idea behind this is, I'll let Dale speak for themselves, but some of the testimony was about coming into alignment with what other states are doing and modernizing the existing program.
Okay.
Yeah. Okay, so the next bit of language is specific to the assessment portion. So an assessment, to the extent reasonable based on a report, shall include an interview with the reporter of the alleged victim, focusing on ensuring immediate safety and mitigating future risk of harm, a determination as to whether the alleged victim meets the definition of a vulnerable adult, and whether allegations, if true, meet the definition of abuse, neglect, or exploitation, and then identifying resources and protective services needs to reduce the risk of future maltreatment and improve care and safety of the alleged victim.
I can see how the definitions are going to be so critical.
Mm-hmm.
Yeah.
Services offered during or at the conclusion of an assessment can only be implemented through voluntary agreement or court action. If an assessment closes without resulting in an investigation, there's no finding of abuse, neglect, or exploitation, no indication if of the intervention on the Adult Protective Services Registry, but Dale shall document the outcome of the assessment in its own records. Dale must provide written notice of the outcome of assessment to the victim and the victim's representative. And then we have language specific to the investigation. Dale is required to notify the reporter if it decides not to investigate or conduct an assessment within 5 business days of its decision, and inform the reporter that the reporter may ask Dale to review that decision. And it shall also notify the alleged victim and alleged victim's representative in writing of the outcome of the investigation within 5 business days of its decision, and inform the victim or the victim representative that either may ask Dale to review the decision. Unless it will jeopardize a vulnerable adult's health or safety, the investigation must include the following: an interview with the alleged victim, unless the alleged victim objects, and an opportunity for the alleged perpetrator to be interviewed. If the person declines, either by notice saying they're declining or failure to respond, the alleged perpetrator will be notified that the declination may be noted in the investigation and may be considered in any potential appeal process. At the conclusion of the investigation, an investigative summary is submitted to the commissioner or the commissioner's designee describing the evidence and recommending either substantiation or unsubstantiation and whether placement on the registry is appropriate. Dale needs to interview the alleged perpetrator before substantiation unless the alleged perpetrator declines that interview. And if a recommendation is for substantiation, the alleged perpetrator must be given written notice by certified mail of the recommendation, the summary of the evidence for forming the basis of the recommendation, any remedial options, and how the substantiated report might be used. The alleged perpetrator may seek an administrative review of the placement of the person's name on the registry by notifying Dale within 14 days after the date listed on the notice of the right to the administrative review. The commissioner may grant an extension of up to a total of 28 days for good cause. Administrative review of Dale's intent to substantiate may be stayed if there's if there's a case pending in the criminal or family division of the Superior Court arising out of the same conduct, during which time Dale may add the alleged perpetrator's name to the registry with a notation that the case is pending. So if a court is looking at the same allegations that's giving rise to the investigation, there's sort of a pause in the administrative review process until the court process is complete. But during that time, the person's name is still on the registry with a notation that that the case is pending. It hasn't hasn't fully gone through the process yet. So the alleged perpetrator may exercise that right to review upon the resolution of the court case by requesting that it be reviewed in writing within 28 days after the case has been fully adjudicated. Otherwise, the decision becomes final. If the administrative review is requested, it shall be held within 28 days. At least 14 days before that review, Dale must provide certain information to the alleged perpetrator. At the review, the alleged perpetrator may present evidence or information, and Dale has the burden of proving that a reasonable person would believe the vulnerable adult was abused, neglected, or exploited by the alleged perpetrator by a preponderance of the evidence. Dale must establish a case review unit that may contract for administrative reviewers who are neutral and independent arbiters with no previous involvement in the investigation. So they're conducting that administrative review. Within 7 days of the completed administrative review, the reviewer shall either reject or accept Dale's recommendation of substantiation or defer a recommendation and direct Dale to go back and do further investigation and notify the alleged perpetrator of its decision. And where appropriate of the opportunity, the alleged perpetrator's opportunity to appeal the administrative reviewer's decision. If the administrative reviewer accepts the recommendation for substantiation, a registry record is created within 2 business days, and otherwise there wouldn't be a registry record. In exceptional circumstances, the commissioner, but not the commissioner's designee, so only the commissioner, could reconsider an administrative reviewer's decision, and the resulting penalty of creation of a registry record could be appealed to the Human Services Board. So just to sort of walk through the levels of review. So first, there's the investigative summary that Dale is creating. And the alleged perpetrator would receive what that summary is. And if it is a recommendation for substantiation, the person could say, no, I want this reviewed again. In which case that is an administrative review by a reviewer who has not been involved in the case. So that's the administrative review level. They could accept Dale's recommendation to have a substantiation. And at that point, the commissioner, him or herself, may override the decision that the case is substantiated. Or the alleged perpetrator could seek review by the Human Services Board. So there's a series of steps to have the decision looked at.
I may have missed this. Regardless of the outcome of the complaint, is as soon as the complaint is triggered, is the alleged perpetrator put on leave?
That's not addressed in this bill.
Oh.
So what happens in practice would be a better question for the department. Initially, the department is sitting with the information, and depending on what their determination is, are they going to do an investigation or an assessment? The person's employer might not even know at that point that anyone is looking at specific behavior. So I think that would be a question to save for Dale when they testify about what happens.
Thanks.
May I ask just a kind of a background question? Did you follow this through the House? Were you is this really targeted more for, as Senator Gulick mentioned, like employees in long-term care or healthcare settings, or family? What's the real, where's the problem?
I don't know if I can answer where the problem is, but the product of this process is a registry that employers who serve vulnerable adults can check prior to hiring somebody.
Gotcha.
Yeah.
Thank you.
Okay. So within 30 days after receiving notice of the substantiation, the alleged perpetrator may apply to the Human Services Board. The resulting expedited hearing shall be provided not later than 30 days after the notice of substantiation. So the Human Services Board can take a look. Records are retained confidentially for 6 years after an unsubstantiation. So the department will still hold on to those records for 6 years. The vulnerable adult, the adult's representative, the alleged perpetrator's employer shall all be notified upon the final determination. Remedial action. So 6907, Dale shall pursue protective services if they have not already been put in place and the investigation shows that the vulnerable adult has been maltreated, assuming consent from the vulnerable adult's representative, or a court order. If the vulnerable adult's representative is responsible for the maltreatment and refuses to consent to the investigation or protective services, the investigator can seek a court review of the representative's refusal. Failure to consent to protective services does not automatically end the investigation. We have language about retaliatory action by an employer is prohibited. So there's new language that specifies that this section does not provide immunity to a person reporting their own perpetration of maltreatment. It would still go through this process. Interference by a caregiver with regard to receiving protective services from a vulnerable adult. So the new language is mostly technical. We have some conforming changes, but it repeals the authority of the court to modify the terms of a coordinated treatment plan. Then records of abuse, neglect, and exploitation. First, we have language about access to records. So subject to confidentiality and privilege protections, APS shall have access to any records, documents, including client identifying information, financial records, medical and psychological records necessary to perform its duties. Persons or entities with a record or document that APS needs shall make it available to APS. If made in the course of an investigation, Dale is not required to pay a fee to acquire the financial or medical record. If it cannot otherwise access the record, Dale can petition the court for access. And on good cause shown, the court may order the person or entity in possession to provide access under the court's terms. A person or entity in possession of a record is entitled to notice and hearing and access to confidential access to a confidential record is not a waiver of confidentiality. A person who discloses the alleged victim's information to a Dale investigator in good faith has immunity for the disclosure unless the actions constitute negligence, recklessness, or intentional misconduct.
So where is HIPAA in all of this?
That's a good question. And I know Vermont Medical Society, I can speak
Well,
for
I've got
Has-
questions
has-
about it.
has,
It seems like it's,
has raised an issue since this language has been adopted. So I anticipate you will be hearing from Jess
okay,
at some
so
point.
get some testimony on that. Yeah. Senator Williams.
Can you go back to the section 6910?
Yes.
Why does it repeal the authority for a court to modify terms
Let me look at
of
the
court
language.
means treatment plan? It's on page 4.
Yeah, I'm looking at the underlying language in the bill. The court may modify the terms of a coordinated treatment plan. I don't remember the discussion specific to removing that sentence. So I would suggest that's another question for Dale. This bill is being taken up at the request and the work that Dale and other partners have put together looking at the APS program. So I
Okay.
don't have an answer to your question.
We'll have to get testimony. Was there any testimony from the medical practice board or others overseeing professional practice? I mean, given that we're now opening up records,
Yes.
I'm assuming that there's some attention given to medical care here.
So let's see, BMS was in the room, Jill Alston was in the room, she's home health providers. Laura Pelosi was she
Well, yeah,
representing
well, look,
nursing?
we'll
Yeah.
get folks.
So yes, I don't have an exhaustive list, yes.
I know. The list is a mile long. Yeah, okay.
Okay. Did I get through this access to records? Yes, so then we move on to confidentiality. Confidentiality of reports and documents. So information obtained through reports to Dale and assessments and investigations conducted by Dale, including the identification of the reporter, are confidential and cannot be released absent a court order, except to those certain individuals listed in statute may receive a final investigative summary report. This language allows for the necessary disclosures to conduct investigations, to make referrals to law enforcement agencies or Dale grantees, but reasonable efforts must be made to limit information to the minimum necessary. And financial records disclosed to APS may only be used in a judicial or administrative proceeding or investigation directly related to a report. In terms of the registry, Dale is required to maintain a registry of substantiated providers that contains the name of individuals who regularly work or interact with vulnerable adults who are found to have maltreated a vulnerable adult and their role and the adequate date and nature of the finding. Names of individuals convicted of a crime related to maltreatment, and also a personal identifier aside from the individual's name in case to avoid confusion of two people who may have the same name. A person can apply to Dale for expungement of their name from the registry, and Dale must consider the person's completion of reparation and rehabilitation in deciding whether to expunge. Disclosure of registry information.
Can I go back?
Yeah.
And just a question of clarification. I know we worked very hard on the release of financial records, and we worked with the folks from the banking, from banks. Is that process still in here?
Um,
Do you know?
so there was a request, from Dale to have language addressing banking. The gentleman from the Bankers Association, representing the Bankers Association, came in and felt like that language needed more time and more work. So what you'll see is that there is, a sort of a working group set up to look at that language and come back with recommendations on the financial piece. Okay,
Thank you.
yes. Where was it? Okay, so the bill includes that an individual seeking to determine if the individual's own name is on the registry is added to the list of individuals who the commissioner or the designee may disclose registry information to. So the registry isn't just open to anyone who wants to see whose name on it. There's a list of people who have access to the registry. If you're a person who wants to know if your name is on the registry, you now have that authority. Your name is added to that list. And then it removes a fine of $500 for persons violating this section. Section 6913, penalties. So this increases the penalties throughout this section. Requires Dale to investigate allegations that a mandated reporter failed to make a report when the investigation appears appropriate. And when Dale finds that a mandatory reporter willfully or knowingly withheld information or provided false or inaccurate information, Dale may impose an administrative penalty of not more than $1,000, or may impose an administrative penalty of not more than $1,000 per violation.
Is there a difference between a mandated reporter and a mandatory reporter?
No.
Oh, thank you.
Good question.
Is it mandated in the title heading in 6903?
I've always known it as a mandatory reporter.
Yes.
So.
I'm curious now.
Go ahead.
Where is it? I'll just flag it and look at it on my own time.
Okay.
Can't find it right off of that.
Good question. Well,
Disclosure of registry information, why did they remove a fine for person violating the section?
Let me look at the section. 6912. Any person who violates the section will be fined not more than $500. Another question for the department, why was that proposed to be removed? There are penalties in the next section, and I'm not sure if they felt that those penalties would cover any violation of this chapter. No, those are specific to mandatory reporting. Question for the department, I would say.
Make sure we ask that when Dale comes in. We got a bunch going on here.
Access to criminal records. This removes the provisions allowing employers and organizations serving vulnerable adults to ask the commissioner to obtain information from the Vermont Crime Information Center about current and prospective employees, volunteers, and contractors.
That's another question. We'll have to
Access to financial information. So the new language in this section is mostly technical and conforming changes. It removes the ability for financial institutions to charge Dale for the cost of providing information. But you'll see when we get there that there is that standalone section on financial records. There's a new section. So up to this point, we've been amending existing laws. So there's a new section entitled Written Communications, and this just requires that any communications from Dale, the administrative reviewer, or the Human Services Board to either the alleged victim or the alleged perpetrator has to use plain language. Then we have a rulemaking section that directs the commissioner to adopt APS rules, including rules on referrals, assessments, and investigations that conform with the chapter.
Is there any specificity to what is being asked for?
There's some.
Okay.
I have to look because we actually had a conversation about how much specificity was the right amount, so let me see where they landed. It's been several weeks since I've looked at this bill now. Yeah, so they landed on a place of more specificity than less. They had a conversation about just having language that says adopt rules necessary to implement this chapter. And they ended up with a longer list.
Okay. well,
We'll take a look at. Okay, so the next section 2 is, we're in the same chapter, the APS chapter. We've just moved on to subchapter 2, which is maltreatment prevention for vulnerable adults. There aren't many significant changes here. Most of the changes are in subchapter 1. So in section 6932, we have conforming amendments like changing plaintiff to vulnerable adult and the addition of the word neglect. In 6933, request for relief. It specifies the APS staff can seek relief from maltreatment on behalf of a vulnerable adult, and expands the types of protective court orders that can be sought to protect a vulnerable adult. Notice section is just adding gender neutral language, so not substantive. Then we have a section 3. This amends the advanced directive statutes to allow APS to seek judicial review of the agent's authority to refuse protective services for a vulnerable adult. And then in section 4, this is the financial protection piece. It requires Dale, in collaboration with DFR and representatives of financial institutions, to report to the policy committees by November of this year any proposed legislation to change protections to vulnerable adults with regard to financial abuse, neglect, and exploitation.
So going back to let's go back to the advanced directive. Piece.
Yeah.
So,
Pull that up.
yeah, so what is that doing there?
So right now, in existing law, there's a list of who may petition the probate court under that particular section. So who can seek a review of an agent's authority under advanced directive. And so this is adding, allowing APS to seek that judicial review of agents' authority. So for example, if an agent of an advanced directive is maybe refusing protective services, or maybe that is the person who is alleged to have conducted the maltreatment, this allows APS to petition the court to seek a review of that person's authority to perhaps restrict protective services.
Even if there is an advanced directive that is allowing for the decisions that the agent is making? Well, we'll have to sort that out.
The thinking or the conversation is that if that person is potentially the perpetrator of maltreatment, and then they're preventing further investigation or further protective services to the vulnerable adult, that creates an opportunity for the court to look at that.
But they'd have to be superseding the advanced directive. We'll just have to sort that out. Okay.
There are other items on this list: a social worker or healthcare provider employed by or directly associated with the healthcare provider, healthcare facility, or residential care facility providing care to the principal. So those are all people who can petition the court to look at the advanced directive. A representative of a state designated protection and advocacy system if the principal is in the custody of DMH.
So it opens advanced directives up in a new way. Okay. All right, I'll have to look at that.
Yeah, it adds a sixth party to the list.
Okay. And then the last piece is the
Active date.
collaboration with DFR.
Oh, yeah.
This is the, go ahead.
So, yeah. Section 4 is that financial piece. So Dale working with DFR and financial institutions is proposing legislative language. They're going to look at financial abuse, neglect, and exploitation over the summer. And they would come back with a report November 1.
Okay, and then,
And then-
but there's nothing in here about exploring how broadly HIPAA is transgressed or changed.
There's not a report on it, but I think that it's worth hearing testimony
Yeah.
on the records piece, and I think
Okay.
that piece could be potentially tightened up there.
Yeah,
Yes.
okay,
I think that's where we would address it.
okay, good, thank you. That's great. Any questions, committee? There's a lot here.
I kind of have a tangential question about the financial abuse piece, which is just that so many folks are vulnerable to scams and, phishing. Does, is a person who's caring for an older vulnerable adult who is a victim of like a scam, I mean, will they be held responsible for that?
That's a
And
good question. Ask our lawyer.
I mean,
so that's very sort of like second and third tier, but still, it just seems.
again, this is a better question for Dale, but my understanding is that they handle complaints about financial abuse, neglect, and exploitation.
Other questions? So we'll get some testimony, and it sounds like Dale is important to hear from pretty quickly. And then others, we'll look at the list and we'll try to bring folks in where it would be helpful for me if you would give me the sections that you're most concerned about. We can get some testimony on those sections specifically, but we're gonna have to go through the whole thing again and word by word. The definitions, as you said before, I was starting to read through some of the definitions. You think it's worthwhile looking at any within the next 10 minutes or?
We can start it. I was gonna suggest maybe setting aside 45 minutes one morning to go through,
Let's do that.
but if you have the time, I'm happy to start.
Well, we're actually have some time pressures as we begin H 222. So we might be able to pick up our testimony a little earlier on that. I think, is Sarah available?
I'll reach out.
Yeah, okay, and then do you have a sense of which definitions have been expanded the most?
Yes.
Can you just share with us which
Yeah,
those
you know
are?
what I'm gonna grab really quickly? I already use copy of every change that has to be.
That always helps.
Yes, okay. So abuse received substantial conversation. There's a new definition of acts of a sexual nature. That's a whole new definition.
What page are we on?
Page 4, activities of daily living is a whole new definition.
Okay, so I just want to check off the ones that you.
I mean, you can tell which ones are new because they're underlined, but in
Yeah.
terms of conversation,
All
caregiver, they spent some time looking at the definition of caregiver, some time looking at the definition of exploitation.
oh, I marked caregiver already. Okay.
Mandatory reporter, they spent some time on just trying to decide whether to define it in the definition section or cross-reference it. And we ended up cross-referencing it, but there was a bit of back and forth about how to handle that piece. Neglect got quite a bit of conversation. Let's see. We talked a bit about, vulnerable adult, that got quite a bit of conversation.
Which one?
Vulnerable adult. So I'd say those are the major ones. Abuse, neglect, exploitation, vulnerable adult, caregiver.
All right, so. Thanks, that's helpful. So what we'll do is, as we go through the bill ourselves and read it through, we've got some places to focus on as the definitions are plunked into the rest of the bill. It'd be helpful to consider all that. Okay, any other questions? And there's one working group in here?
Yes, I call it working group light because it's not really
Not really.
fleshed out as to the specific parties, it just talks about representatives of financial institutions, but it's more of a report in collaboration with others.
Okay. Are there any legislators in that working group? It's
No.
all pretty.
Yeah.
Format out there.
Stale, DFR, and then
Yeah.
representatives of financial institutions.
Thank you. All right, so we have been through H 222.
Yeah.
Can you give us remind us?
Yes.
That would be great.
Do you want me to pull up my section by section? I won't go through
Yeah.
it all, but
Yeah, let's do that.
I need it to jog my memory just as much as anything else. Oh, do you know what day that was, Alex? That it was
I think
posted?
that was the 30th. I'm
Yeah.
pulling that up now.
Thank you.
I'll repost it for today.
Oh, there it is. Okay. Okay, so it's pulled up on the screen. I won't go through every section, but very high level overview. We have several sections about expanding prescription drug disposal to include needle and syringe disposal. There's a concept of regional stakeholder meetings and appropriations tied to that expansion. Also, there is an increase in the drug manufacturer fee from 1.75% to 2.25%. And then there's a presentation by the health department on needle and syringe services. There's updates to the opioid antagonist section of law. There is a definition section that exempts other harm reduction supplies from the definition of drug paraphernalia. In terms of prescription drug coverage, there's language that prohibits a health insurer or other health benefit plan offered by an insurer or pharmacy benefit manager on behalf of a health insurer covering prescription drugs from the step therapy, fail first, and other protocols. So that's the adverse reaction piece. We're updating MAT to be medication for opioid use disorder. Various amendments to the opioid use disorder treatment system, including more flexibility in rulemaking, more expansive language with regard to who may dispense substances to treat opioid use disorder, allowing controlled substances for use of opioid use treatment to be prescribed via telehealth to the extent permitted by federal requirement, and also language that applies to DEVA regarding to the adverse reaction documentation. We have language in section 7 that requires HS to provide coverage to Medicaid beneficiaries for medically necessary medication for opioid use treatment when prescribed by a healthcare provider acting within their scope and participating in the Medicaid program. Then pending approval from the Drug Utilization Review Board requires AHS to cover at least one medication in each therapeutic class from Medicaid's preferred drug list. There's prior authorization recommendations on legislative action. Oh, this is coming from Joint Legislative Oversight. This is for individuals reentering the community after being in an incarcerated setting. We have a gold card program report. Rulemaking for prior authorization. This is the change from 16 milligrams to 24 milligrams for individuals and office-based programs to be consistent with hubs. There's a a carve out for recovery residences and a definition added of recovery residences, and then repealing the future repeal of the buprenorphine exemption. So,
Okay, good. That's
quick overview.
Yeah, no, we've been through it, so now we've refreshed ourselves. And thank you for that. We have someone on Zoom who has to get to her patient. So is she there? Alex?
She's not joined us yet.
Okay. And Sarah, I think we need to hear from Katie Marvin because she has to see a patient coming up. So we're hoping she'll zoom in, but then you'll be up next.
I haven't felt sensitive.
Oh, good. Oh, I thought it was 10. Did you let her know?
Yeah.
Oh. Good. So on the H-171 bill, please go through the bill, look at those definitions that Katie identified in particular, and then the HIPAA issue, which I think is pretty critical, we should also consider.
Yeah.
And then think about the timelines that are in there. We'll have Dale in to answer the questions. And then process. Not a simple bill. It's huge. And we're all getting emails.
Yeah.
And the question that you asked, Senator Weeks, regarding families versus institution or, residential homes or long-term care, I think that's a really important question to ask. And how do you identify abuse and neglect when it's one family member, another? If there aren't other people involved, even if there are.
May I ask, if it's known what was the genesis of this modification? Like, did it come through advocacy?
I think it's the department itself looking to improve language, and we'll ask that question when we have folks in. There's a companion bill up on our wall, I forget the number of it, that I was asked to introduce.
51.
Isn't it? Is it the APS? Is it up there?
51.
Yes,
Yeah.
if you want.
Oh, good. Yeah.
Her eyes are better than mine.
Is she not available?
I'm trying to figure out what's going on. Jill is my contact with her.
Okay.
I sent an email.
So Sarah, while we're waiting, I know that your testimony may not be long, so let's see how it goes. And if I interrupt you, I'll do it with apologies.
Okay, thank you.
Senator, I'm actually here to tell you that they're very early out front. They are anticipating your welcome.
Oh, for the Alzheimer's awareness?
No, for the prevention day.
So we're on a pretty tight timeline. So how many people are out there?
It's all the students from the Prevention Coalition.
Okay, well, okay, I'm gonna leave and I'm gonna turn it over to Senator Weeks.
I promise to bring her right back.
This man has been in foxholes and he freaks. He just got a little nervous.
Just like an iceberg.
Not her.
This was mentally prepared for.
Thank you. Okay, I'll be right back.
So,
It's like a very specific language thing, right?
Yes.
Okay.
I did send an email to you all, and if you don't have it, I can send it again. I'm Sarah Teachout, representing Blue Cross and Blue Shield of Vermont. And I asked for what I believe is a technical amendment to H222. And what we'd like to say at the very end of section 3, which is the thing that provides, the section that says that you cannot have step therapy fail first or other protocols. We want to say unless required by the FDA or by the product labeling. So there are some instances where the FDA or the manufacturer on the label of the product requires something like that. And so in those instances, we want to be able to do so. We support every other part of your bill. So I think it's pretty narrow. The reason I'm coming here is I was a little late on the House side and they said, oh, the bill's already moving. Can you bring this to the Senate? So I did talk to Representatives Wood and Whitman about this, and I believe they are supporting.
It's section 3A, right? Is that the manufacturer fee?
Sorry, I
No,
don't have
that's
the whole
okay.
bill with me.
Because there's a 3,
3A,
I got it
and
right
then
here.
this little
Right
3.
hand,
I
yeah.
only cut out the tiny
Hey,
part of the
Katie,
language.
oh, it's in
Katie,
section
Katie,
6.
you're still LinkedIn?
Nope, I'm
No.
not.
Because I like to display it.
Yep, I mean.
If, maybe
I'm sorry,
Alex,
I
if
should've-
you-
No, that's okay. I'm just trying to.
let's
find
just
it.
drill right into
Sure.
Prescription
Can
drug
you-
coverage, section 6.
Are
Is that
you
what you said?
saying?
Yeah.
I'm logging it in. Oh, it says in mine.
Katie, did you know where I was suggesting?
It's section 3, or is it not section 3?
Well, there was a little 3, but I don't know if that's actually the section or
Oh,
just
Yeah,
the,
it's section 6.
Okay,
Yeah.
Okay.
subsection 3, maybe?
Yeah, Jess is right. It's section 6, 8 VSA 4089I, prescription drug coverage. Yeah, page 9, paragraph 3.
There we go, sorry.
There is a 3 involved.
I just cut and pasted the tiny little bit, so.
Right.
Yeah, that's it.
So after that substance use disorder, the very last 3 words, we'd like it to say, unless required by the FDA or by the product labeling. The example that was given to me by Nancy Hoag, our Director of Pharmacy, was Sublocade, which does require step-through oral buprenorphine. I'm not very good at these, or a combo product. So there's, she gave an example of an instance where the product labeling requires this.
Mhm.
So we'd just like to be able to comply with the product labeling or the FDA.
Okay.
Okay,
Have you sent
I
that
did.
to Alex?
Yep. Do you have it, Katie?
Yeah, I just put it
It's
in.
been posted.
Okay.
Okay.
I thought I was pretty comprehensive with who I sent it to, but you never know.
You
I know
how it
you all get a
works.
million emails.
Yeah.
Okay, thank you. I appreciate it.
It's good. And is that Katie Marvin?
Yes, I believe that Dr. Marvin is available to speak now.
So Dr. Marvin, if you can come activate your camera. Thank you. And if you could introduce yourself for the record and provide your testimony.
My name is Katie Marvin. I'm a family doctor in Morrisville and Stowe, Vermont. And am was the president of the Vermont Academy of Family Physicians for the last few years until recently, and am a prescriber of buprenorphine locally in a spoke setting for roughly 50 patients who are also in a primary care office. I think from a testimony standpoint, as I testified a few weeks ago, in general, I would like to just reduce any barriers to care for patients who are being treated for opiate use disorder. In the spoke setting, we provide comprehensive, fairly immediate care for any patient that presents, even if they aren't our own patients. And we've really extended ourselves as local primary care to do this with, trainings and hours and just really trying to make sort of any door the right door with a lot of community projects. And I think philosophically, I was testifying essentially to try to remove any other barriers because we've done really everything we can to remove barriers to care. And prior authorizations in many cases do limit the care that you can provide immediately. And the whole point of our RAM program, which stands for Rapid Access to Medication, is to provide immediate care. So prior authorizations, if they delayed that care, could really sort of unwind a lot of the work that's been done at the spoke level, which I find to be a very successful program.
Okay, thank you, Matt.
Can I just ask a question?
Sorry.
Dr. Marvin, do you have any specific suggestions or changes that you would recommend in the bill as it is right now? Or are you just wanting to make us aware more generally?
I don't have any specific suggestions. I think in general, my recommendation is just to try to support the providers on the ground as they really try to improve access to care. And as I testified to the House, I really think that Vermont should take pride in the availability of MAT at the spoke level. It's really unlike anything at any other, in most other states. I was lucky enough to represent Vermont at the Congress of Delegates in DC. And, in talking with a lot of other representatives from other states, we really have expanded the access using primary care, and it's not really being done anywhere else. It's really cutting edge. And it's very safe. There haven't really been any negative issues. The prescribers are doing a great job, and they've really had to extend themselves in already busy practices to do that. But it's very rewarding work, and the patients are able to present and to get really comprehensive care, and very confidential care. So they're not having to go to quote unquote treatment center or even a hub where they might feel more stigmatized or even just exposed publicly. So I think, just from a philosophical standpoint, why limit or why have prior authorization requirements for prescribers who are doing a great job in providing safe care that's very cutting edge? It's important to enable those prescribers to do what they think is right in their experience. I think that the other information that might have been helpful in the previous testimony was if somebody has, for example, demonstrated an allergy or intolerance to a single product in the past, I don't require that they quote unquote fail that product again. I just try to make it akin to any other medication intolerance or allergy and believe the patient. We have many other sort of layers of oversight, for lack of a better word, to ensure that patients are gaining more stability with their path to recovery. And because we provide sort of a comprehensive approach at the spoke level, I think we get to know them very well. And so again, I wouldn't require quote unquote failure to a product that they have an allergy to. I'm happy to take any other specific questions. I don't have anything else directly prepared.
Thank you, Senator Hardy. Any other questions? Senator Williams? Okay, well, thank you, Dr. Marvin. Appreciate your time and certainly appreciate your efforts in the field. Thank you very much.
Thank you. And anytime if you have follow-up questions, I'm happy to receive them.
Thank you. Appreciate that.
Take care. Bye.
Bye-bye. Jessa Bernard. Yeah, Jessa?
Sorry, Senator. I think we actually want to do Nolan first.
Yeah, sorry. Yeah, Nolan, you've got a 10:30 obligation. So if it's okay, Jessa, we're gonna, okay, thank you.
But that's okay. I think my schedule has changed. But anyway,
Well, you're up.
I'm up. All
You're in the
right.
seat.
Great. Morning, for the record, Nolan Langwell, fiscal office. So there's a fiscal note, and I'm here to talk about the fiscal note. It should be on the webpage. There are 3 things in this bill that have fiscal impact. The first one is section 3. There is initially it was called an appropriation, but now it's an authorization. It's an authorization of $150,000 from what is known as the Evidence-Based Advertising Fund. And that's a fund that to help, yes.
Would it be helpful to bring up your note, or are you okay?
Yeah, you can watch online. I'm just going through it if you want. If you want it up there, it's fine.
I don't see it on here.
And that is
I don't
not
either.
mistake, it's getting posted as we speak.
Oh, okay.
Ah, okay.
It's short.
Short and sweet. Hopefully it'll become longer soon.
It's short but impactful.
It's short,
Impacts a
but
wall.
it's short and waiting to be amended.
Aren't all bills?
Mhm. Not all bills are short.
The ones that live here are not made. And then Alex, when you do pull it up, you could just kind of scroll to the summary just to keep it simple. It's on the second page. Yeah, perfect. So again, the first piece would authorize $150,000 from what's known as the Evidence-Based Education and Advertising Fund. I'll talk a little bit more about that in a moment. That's a fund that's used to fund a lot of different public health initiatives that the health department does. And this would be specifically to provide grants and consultations for municipalities, hospitals, community health centers, and other community needle and syringe disposal programs. So it's just allowing them to use the fund in statute has various purposes, things it could be used for. And this basically allows for this new purpose to be used for that. The second piece is this thing called the manufacturer fee. This is tied to the evidence-based fund because the manufacturer fee is what goes into that fund. And what that is it's currently a 1.75% assessment on the previous calendar year's prescription drug spending by the Department of Vermont Health Access. So it's a way that the state assesses a fee on the manufacturer, and they base it on basically underlying spending by the Department of Vermont Health Access. And what this bill does, and Senator Lyons is well aware of this fee because she has initiated previous. You might have even been when it was created.
Which one?
The manufacturer fee.
Oh, yeah.
And the bill proposes to increase that fee from 1.75% to 2.25%. And that raises an additional $1.3 million that's charged to the prescription drug manufacturers. And that money goes into the evidence-based fund. And I recommend that when you get to this section of the bill, if you go into discussions of it, I recommend you have legislative counsel walk you through like what currently goes into the fund and allowable purposes to give you a sense of what it is that they're trying to raise money to pay for.
Yeah, that's a good generic question. Actually involves one of Senator Hardy's activities. As opposed to, was it considered instead of raising the fee rate to utilize money which is in the opioid settlement fund? Is that?
This is different. This is a fund that's been around for
A long time.
a long time, at least 10 years.
So the prescription drug manufacturers pay a percentage of the price every time one of their drugs is sold to Medicaid. What's the final line?
So I actually have a little issue brief on this.
Oh.
And maybe, Alex, I think you can find it on the Ways and Means website. You can actually post it.
Yeah.
And I don't want to go, we can, or we can go into it another time and we could walk through what it does. Jen and I
Well,
wrote this
if we put
together.
it up and we look at it, then if we have questions, we can ask another time. Is that
Sure.
okay with you?
But basically the fund, this issue brief kind of lays out 2 pieces. It lays out what the manufacturer fee is and then what that money is allowed to be spent on in statute. You can change the statute and spend it on other things. And that's essentially what they're proposing to do, one of those things. But usually it's within the line of spending on addiction, particularly on opioids and prescription drug addiction. So that then tends to be in health department has, I don't think they've ever deviated spending that money on anything else but. So that's the second piece. And again, I can imagine we can have another further conversation, but meanwhile, Alex will post that on the website. And it's just a quick 2-pager, talks about how much is in the fund, how much revenues are raised, what the money's been spent on in the past. So it's a good sort of primer of what that fund is. So when you get into the details of this particular section, when you start having a conversation, I think it'll be a helpful resource.
Thank you.
And the last piece in here is section 8B. There's a language that would require DVHA to amend its rules to enable healthcare providers an office-based opioid treatment programs to prescribe 24 milligrams of buprenorphine without prior authorization. According to DVHA, this change could have an estimated fiscal impact of approximately $1 to $2 million per year. The language in here is could have. It's not that it will have, and partially because this is an estimate, they don't really know, but they think there will be a fiscal impact. And that's just the range of what they think it is. So the House sort of took the angle of, great, if it has an impact, come back and budget adjustment. They may come in here and disagree with that, but I put it in the fiscal note because whenever DVHA says it's going to have an impact, I feel it's my obligation to make sure that you know that. Those are the three big things in the bill that have fiscal impact.
Okay.
Okay. Told you, a short little walk.
All right, thank you. So we'll move on to Jessica Barnard. Thank you, Sarah.
Good morning. Thank you for having me. Jessica Barnard. I'm the Executive Director of the Vermont Medical Society, representing physicians and physician assistants, and we are here in support of H222. In general, we support the whole intent of the bill to increase access to harm reduction strategies and medications for opioid use disorder, and I'll go into a little more detail on some of the specific sections that we work most closely on and that our members are sort of most paying attention to, but again, support the bill overall. So I'll in particular be addressing sections 6, 7, and 8. They modernize language around treatment for opioid use disorder and remove barriers like step therapy and prior authorization for access to medications for opioid use disorder. So I'll be referring to that as MOUD or MOUD. These changes will help prevent costly delays when patients are ready to take the critical first step to recovery, and will also help alleviate unnecessary administrative burdens on healthcare providers. So a little background on step therapy. This is addressed in section 6. This is often called fail first protocols. They are requirements by health insurers that require a patient to try one medication and then document that that was not successful for whatever reason before being allowed to try another medication. And it's not just in the opioid use disorder setting. There are protocols like this for cancer treatments, all sorts of medications. But in this bill, we are limiting the conversation to opioid use disorder. There was a lot of testimony upstairs in the House about not just requiring a step therapy or fail first protocol, but specifically requiring documentation through this FDA form called Form 3500 or a MedWatch form, and requiring a clinician to actually observe and document side effects of certain opioid use disorder medications before allowing the use of another. This was not what that form was intended for by the FDA. It's intended as a voluntary sort of self-reporting form of side effects to track side effects of medications, but it's been adopted by some insurers as kind of a mandatory hoop to jump through rather than sort of voluntary reporting. So our VMS, our members oppose step therapy payer policies in general, and I've included some links to articles about sort of the use of step therapy more broadly. But in particular, in this instance around opioid use disorder medications, we strongly support the language added in the House regarding prohibition on step therapy for MOUD. I did hear Blue Cross Blue Shield's testimony. That's the first we've heard about this technical suggestion around if the FDA requires the use of a form. I think I'd like to talk to Blue Cross a little bit more about it. I'm actually a little uncomfortable with where it's being put in the language because it's being put in a section that's saying insurers can't require certain documented forms or failing on a medication first. I think if the FDA or a product label requires its use, that is something that the prescriber then would have to do before prescribing the medication, but I'm still not sure we're comfortable with insurers requiring it or that it's necessary in that section of language. I think if the FDA requires it, that wouldn't, that would still be a step that the provider would need to take without saying that the insurers could then also require it. So I guess I'm just not quite sure why Blue Cross thinks they need the exemption in that location. So before saying that we're comfortable with that proposal, I'd like to talk to them a little bit more about that. Jared, would you like me to keep going through all the sections or do you like questions on the individual sections?
If the committee has questions, I'll let you know. So
Okay.
right now, just keep going. That's good.
So later in section 6, there is language to modernize state statute around the opioid treatment center system. This is Vermont's sort of hub and spoke model where there's the hubs for the patients who need kind of more intensive or frequent interactions or prescriptions, access to medications. And then there's the spoke system, which are really the primary care practices, the more community-based system of providing opioid use treatment. We brought this to the House, realizing that there was some language being modified around this whole statute. And then when we looked at it, we realized actually a lot of the other language is a little bit outdated. Our system of care for opioid use disorder has evolved to treat opioid use disorder like many other health conditions. And some of the language was very prescriptive of what spokes needed to do when they're seeing patients, and also had some outdated sort of stigmatizing language, for example, saying that medication should be tapered as soon as possible, or really highlighting when patients could be discharged from care, which is already addressed in Department of Health rule. And we believe that it's more appropriate to really leave a lot of that to Department of Health rulemaking, which can be updated more frequently, more flexibly. So there's a lot of the language changes in this section are really just streamlining and deferring more to rulemaking than having it in statute. And we support those updates around the spoke practices. There's also within this section, new proposed language stating that clinicians could prescribe MAUD via telehealth in accordance with federal regulations. That's in subsection D of section 6. We strongly support including this language. This is an area where federal regulation is currently undergoing rapid change, especially with the end of the federal public health emergency, which allowed a lot of flexibility for telehealth prescribing. So there are rules both pending with federally with SAMHSA for the hubs, which they call OTPs, opiate treatment programs, and then also for the spokes. The DEA is doing rulemaking for sort of spoke or community-based practices for buprenorphine as well as any controlled substance. Both of those rules have strong language supporting the use of telehealth for opiate use treatments, and the evidence base has really grown over the course of the pandemic that it's very successful, that it has high patient satisfaction, and it's safe and effective. And but they also contain a lot of details, and so we really support the approach of just referring to federal regulation as opposed to layering on additional state requirements or language that may or may not be consistent with federal rules. So we understand that the Department of Health is comfortable with that approach. We talked to them when this bill was in the House, and so we support including that language in the section of bill. Moving on to section 7, this is getting into the area around prior authorization. So prior authorization is the process of prescribers needing to basically request permission from an insurance company before prescribing a medication, or receive permission or approval before a prescription it goes through and is paid for. So our understanding is for Medicaid, for DEVA, that Medicaid already has made it a practice to remove prior authorization requirements for at least one dosage form for every class of MAUD, which is the language you'll see in section 7. It's basically moving that from practice to statute. We support having that in statute. And then I won't go through, in my testimony, I go through more information about how prior authorization can be a barrier to treatment. And that there's actually some good research from the Medicare Advantage program where when prior authorization was removed, it led to a decrease in opiate utilization, an increase in initiation of treatment, and a decline in relapse. So again, we support as much progress as possible in removing prior authorizations. Then the next prior authorization piece is actually in section 8. This is a program called gold carding. I don't think your committee has heard that much about that this session. It's been a topic that the committee's discussed in prior years. A gold carding basically means if you have a high approval rating for your prior authorization requests, that you can then get an exemption. And that's kind of what's called a gold card. Like you don't literally get a card, but it's basically like, you know, you are high compliance. So in this instance, what the bill is saying is if you have a 90% approval rate, so for when you're submitting for payment for buprenorphine prescriptions, if 90% or more of those are approved, sort of fit the prior authorization criteria, you then get an exemption for a certain amount of time from having to do prior authorization at all for that medication. This would be setting up a sort of requiring DEVA to develop a gold carding program for buprenorphine, and we support that moving forward. There has been data collected over the past 3 years when the legislature required Medicaid to report on prior authorizations for MAUD, and that those reports have shown that actually over 90%, 93.2% of prior authorization requests are approved for buprenorphine, only 6.8% are denied. So again, while that's an overall rate, not prescriber by prescriber, that reflects that probably many prescribers would be able to be over that 90% threshold and be exempt from prior authorization. So those were the sections I wanted to specifically call out and mention the background and why we support them. And we really appreciate your work on this bill. We think it's really important to increase access to treatment.
Thank you. Great. So, and we have your comments on our webpage.
Can I just ask a
Of course.
clarifying question? So you're not suggesting any changes at this point? Is that what I heard?
Correct. Yes, exactly. We're in support of the bill as
language
passed.
as it is, and you're going to talk with Sarah about that
I
language
would
in the
be happy.
placement. Yeah, I
So
would like to hear
looking
about
at,
that.
looking at the difference between what Sarah has proposed and then what you're suggesting, there's difference. So I think that probably is a good suggestion, is try and bring us back to something helpful.
Is it safe to assume you were pretty heavily engaged on the health side during the reviews?
We were, yes, especially in the sections that I've been discussing this morning. Yes, we were involved, and they were very open to our suggestions, and we worked closely with them. So we appreciate their work on it and support how it came over to them. Yeah.
Go ahead.
We spent yesterday at Jeb's Promise, which was very impactful, and the removal of barriers just keeps coming up over and over and over again. And I appreciate the prior approval piece here. Is there any way that we can expand on that, or is that too optimistic?
Well, that'll be part of our discussion.
And I'll say we've had conversations over the years with DEVA about prior authorization. The big challenge, to be honest, is that the state, by using a preferred drug list and prior authorization process to sort of require or keep prescribing consistent with the preferred drug list, is that the state then receives payments from the drug companies for being on that list, the rebates. And so if we completely eliminate prior authorization in the Medicaid program, we understand there's a significant price tag associated with that. So philosophically, would we support removing prior authorization entirely for buprenorphine? Absolutely. But we understand that there are financial realities that may get in the way of doing that. So DEVA could probably give you more details on that.
Any other questions? Thank you.
Thank you.
Great, and we'll look forward to some resolutions and the differences, sure, in that section. Teresa Vizina. Thank you for being here.
Thank you for
And I
having
don't
me.
think you've been in front of the committee
I have not.
this time, so we're going to introduce ourselves around, and then that'll serve everyone who is here, has been on it, in the committee room before.
Thank you.
Go ahead, Senator, are you start?
Hi, I'm Ruth Hardy, Senator from Addison District.
Terry Williams, Senator from Rutland.
Ginny Lyons, Senator from Chittenden Southeast.
Good morning, Dave Weeks from Rutland County.
Good morning, I'm Senator Martine LaRocque. I live in Burlington. I'm in Chittenden Central.
Nice to meet you all. Thank you. It's an honor to be able to be here and speak today on behalf of the Vermont Syringe Service Programs. My name is Teresa Vizina. I'm the Executive Director at Vermont Cares. We're here today to talk about two kind of separate things. I want to talk a little bit about the Syringe Service Program network in general. So it's Vermont Cares, AIDS Project of Southern Vermont, the HIV HCV Resource Center, and Safe Recovery. And together, the four programs are able to cover the whole state through our on-site and mobile programs. Right now, we know that it's the most critical time with the opioid overdose crisis continuing, lives being lost every day. We see this, unfortunately, all of the time. And we wanted to, in lieu of coming back tomorrow to talk about the budget, wanted to just say that in FY 24's budget in the House, we had requested an additional $400,000 to be divided equally among the four SSPs to support additional staff. We all work with a pretty limited amount of staff, folks. We cover 14 counties and we have 5 full-time employees. It's difficult, and we're desperately trying to meet the growing need, as well as distributing more harm reduction supplies out into the community. And this is not just Vermont Cares, it is all 4 of the SSPs. So additional funding is really critical at this time, so we can continue to do the life-saving work that is so important to Vermonters who use drugs. So that's one. So thank you for letting me do
Well,
that
we just put
today.
that into the budget pocket, so.
Okay, thank you. And now on to stage 222. We were able to testify in the House as well on this bill, and we support all of the components of that bill. Today, I'm actually here to ask consideration to include some new language, which comes from originally H423. It's now in Senate Bill 119. And what that is a response to public health response to drug use. It's section 14, which I did submit the section for you all, which would provide immunity for on-site community drug checking. This is an issue really close to my heart. It is something that we know and believe is a public health approach to addressing opioid overdoses. It's something that can be implemented today, right now, not a year from now. We're poised and ready.
Can you explain the concept of what you're asking?
Sure. So on-site drug checking, right now, people who are doing drug checking, testing for fentanyl, presence of fentanyl in the drug supply are using what we call fentanyl test strips. So you're all probably familiar. It's very wide-ranging, expansive program. Vermont Cares started using fentanyl test strips in 2016 at our syringe service programs. What we know over these years, what has happened is that fentanyl test strips are very limited, actually. They're an outdated technology. They only can test and give results for the presence of 10 different analogs of fentanyl. What we know in our drug supply today is that there are many more than 10 analogs of fentanyl that could be in the drug supply. There are new synthetic opioids coming down the pipeline as analogs have been banned. It becomes harder and harder to obtain. Therefore, there's still the demand. New synthetic opioids are entering the drug supply, fentanyl test strips will not detect those. So on-site drug checking actually utilizes, I don't want to get too scientific, but a device, it's a FTIR machine, which would allow people to bring in just a sample, not full supplies of drugs, but samples of drugs so it can be tested on-site by trained staff at authorized locations.
Which sites, like, as an example?
Syringe service programs for sure. As a first step, we're already serving those folks and are, I think, prepared and ready to do that for people.
Are you talking about prescribed, legally prescribed?
No, yes,
Okay.
we're talking illicit drugs,
Okay.
which is why the provision is so important. It is an immunity provision to offer protection for people who want to and seek out and then utilize on-site drug checking services at a syringe service program or other authorized harm reduction program. It allows them to safely come in and bring a sample without the fear of criminalization. It also protects our staff who would be providing the service. Knowing what is in your supply is what can save lives, and being able to have results that day, not only will they be able to leave with information, but they're also able to share that information with other people who may not have the ability to come in for on-site drug checking. We know there are other harmful chemicals in the drug supply, like xylazine. I'm sure you all heard about xylazine. This test technology would also identify chemicals like xylazine and other harmful chemicals and other drugs that are being put into the drug supply. So it's just much more informative.
So the language that you're suggesting is, do you have a specified number of these testing pieces of equipment? And then how much do they cost? And who are you suggesting pays for them? And then how are they distributed through the state? So all of those are questions that we would be asking. And I see you've got, I think it's one line on having the testing access, so.
Yeah, so in the language in S-119 does take it into consideration. I'm here in behalf of all the syringe service programs, and so I would say syringe service programs make the most sense to start. The machines are about $40,000.
For how many?
Per machine.
Okay.
If you look at 4 machines, maybe, so 4,
expensive.
yeah, they are.
Okay.
So thank you for your testimony, and I'm looking at the language in S-119, and I just wanted to let the committee know, and I was gonna bring this up later, but the opioid settlement advisory committee did consider drug test checking as one of the things that to fund through the opioid settlement fund, and it would be an allowable use of that fund. So to the extent that there's concern about the cost, and I believe that the amount that we were considering as possibility was $700,000, and it was $100,000 per site. So the machine plus the costs of operating the program per site.
So and that becomes something that needs to be funded over time.
Well, the machine is a one-time cost,
Yeah.
but then the administration of the sort of services of drug checking would have to be an ongoing thing. So that provision, there was a lot of support for it. It didn't make it into the final recommendations, but I know that there were conversations in the House, and that they just sort of ran out of time about putting this in. I think the one rub is that it does require an immunity sort of liability provision, and that does complicate the bill and probably adds a stop or at least a conversation with another committee. But it was something that there was a lot of support for in the opioid settlement committee. It just didn't make it into the final. So, and your testimony is great. I mean, that's similar to what we heard about. A lot of the issues are supply related, that people don't know what's in the drugs that they're using, and they think it's one thing and it turns out to be another thing, and then it kills them because they're not prepared for what is in the supply.
So the test strips are basically obsolete now because of the different variants. Is how long before these machines will be obsolete?
I can't really say on, how long. What I do know is I've talked to companies that have these machines, and so they're ongoing R&D, and they're constantly adding more compounds that that can be tested through the program. So I would hope and imagine that they would continue to go with the trends, and I think this is a time where we can follow the trends and try to stay one step ahead. And I think that this could be very similar to the Good Samaritan law when we look at immunity, just as a true public health.
So would it be something like a software update that they could?
Correct.
Okay.
Yes,
Okay.
yes.
And I wouldn't say that the test strips are obsolete.
No,
Yeah,
It's not
they're-
Well, I
yeah,
guess-
no,
I guess
not-
it's not-
yeah.
They don't test for everything.
Right,
Exactly.
and there are additional, there's right now the fentanyl test strips, and now there are xylene test strips, xylazine. Xylazine test strips are basically about ready to be, I think this summer, and the health department has priced those out, and that's another thing that is in the opioid settlement funds, which, by the way, I'm hoping we attach to this bill, Madam Chair, and that we
Bring
move
us
this
some
out quick.
language to look
I
at.
sent it to you.
Oh,
Yeah,
bring it
The-
here. Bring it here. Send it to Alex.
okay. I think I sent it to Alex as well. But the health department has priced those out as well. If you want, I can send it to Katie to actually draft, but I have the recommendations were sent to you 3 weeks ago and by the Commissioner of Health.
Oh, yeah.
And I've sent them to everybody in the committee. I've sent them to all the relevant chairs. I think everybody's on
We have-
board with making sure that funding gets attached to this bill, and we move this bill as quickly as possible so that we can get this money out to where it's needed in our communities to save lives.
Okay. But could I just have to say, thank you, Senator Hardy, and just to speak to the usefulness of fentanyl test strips and xylazine test strips. This is about offering a variety of options for people. And so they still hold a great value for our communities in other ways. So just wanted to share that as well. So thank you.
Okay.
But I have to say thank you so much
Right,
for
no, and
allowing
we'll
me
be in touch
to share.
if we have any questions about your testimony.
Thank you so much.
And we will be hearing from Department of Health. Get that. Greg Gardner. I think that's you.
Yes, thank you, Senator.
Thanks.
Good morning, everyone. Thank you for the opportunity to be here today, especially in person. My name is Greg Gardner. I'm a senior staff attorney for the Drug Policy Alliance. DPA, as all of you may know, is the nation's leading organization working to advance drug policy centered on science, compassion, health, and human rights, and to end the harms of criminalization and marginalization. For over 30 years, DPA has worked with policymakers in the US and internationally to end harmful drug policies. And for many years, we've had an active presence in Vermont. We've worked with local partners such as Vermont Cares, the other syringe service providers, a number of other local partners as well, on issues ranging from access to treatment and recovery, access to naloxone and fentanyl test strips, distribution of fentanyl test strips, and elimination of criminal penalties for personal use of drugs. I'm going to try not to be redundant to Ms. Zina's testimony. I think it was very succinct and informative. But I do want to provide just a little more context about drug checking. We have worked extensively on this provision, not only here, but throughout the country, trying to advance this as one of the essential public health responses to overdose around the country. As we all know, Vermont's situation is increasing in intensity. The crisis is increasing in intensity. The numbers have gone up again in terms of opioid-related deaths last year and emergency department visits. And this is an issue that needs to be dealt with urgently. And so I appreciate the committee's attention to this bill, work on this bill and support. We of course support, as Teresa mentioned, pretty much all the provisions that are in this bill, but we have encouraged this body to also include the drug checking language. The drug checking language we think is critical because having this additional technology, this additional level of technology provides people with a whole different level and amount of information that they can use, that actually they use. There is evidence to show that people actually change their behavior sometimes when they have more information about the contents of a substance, that they may use in a different way, they may use less, or they may discard the substance entirely if it doesn't contain what they thought it was, they expected to contain. I want to emphasize the immunity provisions in the bill. As previously mentioned, the immunity provisions are extremely important because people need to feel secure to come to a place with a sample. They need to feel secure that when they go to a harm reduction service provider, that they're not going to be targeted, and that they can engage with that person, that service, in a confidential way, and open up and be forthcoming about issues in their life without the fear of criminalization. The technology that this offers is not quickly going to become obsolete. Mass spectrometry is used in forensic labs. It's used in academic research institutions all over the country. It's used extensively, and it's a very refined piece of equipment, a very modern piece of equipment, and it allows us to see all of the compounds, all of the chemical compounds that are in a substance, as well as the concentrations, which really sets it apart from technology like fentanyl test strips. Fentanyl test strips are drug checking technology, but they only provide, one particular point of information, and that is the presence or non-presence of a substance. This allows somebody to find out, really what the potency of something is. And that's a tremendously important piece of information for somebody who is intending to use a substance. The other aspect that was mentioned before in terms of the immunity piece is the staff immunity. Particularly in a state like Vermont that has so many rural areas, one can anticipate staff facilitating the transfer, going to pick up a sample from somebody who really needs it. I mean, that is one potential way that this could be administered to allow more coverage, picking it up and bringing it back to be tested. Certainly would not want that person who's doing that to be exposed, to arrests, to being stopped and being questioned. There are programs that are operating throughout the country and throughout the world. They've been operating for decades in different types of situations, music events, other types of events. Sometimes they are operating in overdose prevention centers. They're operating in the overdose prevention centers that are open in New York, and providing information to people on site about what the substance is that they're using. These programs have been stood up all over Massachusetts, and by the Street Check program, which is a project that was started by researchers at Brandeis. They have done an extensive amount of work in the absence of legislation like this to develop memorandum of understanding with specific law enforcement agencies around the community-based programs where they are working. And that's an incredibly difficult thing to do. And it's patchwork that still provides exposure to service providers and to participants in programs. This legislation would provide a more comprehensive approach to making sure that these programs are treated uniformly and the staff are protected. The funding piece is extremely important. We very much appreciate the interest in the discussion at the opioid settlement committee on these issues, and it seemed that there was not extensive discussion about the amount in the meetings that they had, but it did sound like there was significant support. And we do think that the $700,000 figure is an appropriate amount to try and provide coverage throughout the state if the committee was inclined to do so. I want to be brief, but we do appreciate the work that's been done on both H423 and S119 that contains this language. I think that the language is fairly well developed, and but certainly if there are specific questions about the language, we can try to help in addressing any of those that we may be helpful on. I'll stop there. And if there are any questions, I'm happy to try to address them.
So level of training necessary to operate the machine.
Aspect. I've used it a lot.
You're well skilled in
academic.
everything.
Academic.
So I'm not an academic lawyer, but I do, I think that the Brandeis Project is training lay people to use these projects, staff members who don't necessarily have scientific training to use the equipment. And the equipment's being used throughout Canada, other parts of the world, also by people that are just program staff members who have been trained on it. And I don't think it's an extensive training. Street Check is providing training for community-based partners, and they're willing to work with any community-based partner that approaches them.
Second question, you said that started to use these machines in Massachusetts and New York. Has there been any net effect on reduction of overdoses or any other kind of tangible result?
I can't necessarily tell you that the overdose rates for Massachusetts and the longitudinal tracking of it, but they have tested thousands of samples in Massachusetts. And what the program has allowed them to do is when they spot a certain dangerous chemical in the drug supply, they're able to put out community alerts. And those community alerts go to all kinds of partners, including law enforcement, including health providers and harm reduction providers. Those alerts really do help people know what's locally starting to show up, and it allows them to respond and engage with people a little bit more. If I may add just that one point, I think that one of the collateral benefits of this is that the potential for bringing more people into harm reduction service providers. So expanding the universe of people. Not all drug use is problematic drug use. There are people who have substances who may use even very occasionally who could benefit from knowing that there's not a dangerous adulterant in a substance that they may intend to use. Extremely important, but it can also develop relationships for people who do have more substantive use and who may have things going on in their life that the harm reduction providers can help address. And so building those bridges is extremely important. This is one additional service that providers can offer to the community and can help create more linkages to care.
Go ahead.
I don't know if either of you mentioned this, but there is a pilot program already happening in Vermont in Brattleboro for this program. So, and there's an agreement with law enforcement in that area and the use of one of the machines for a pilot program, and it may also be in Bennington. Is that?
I could speak to that a little bit. Samba from ACE Project testified on this in the House as well. And so we do a lot of work and so they're utilizing the devices that's housed in Brattleboro, but their staff are traveling from Bennington, from their other site, to bring samples, kind of what Gray was talking about, to the machine in Brattleboro. But Samba has shared with me that after the end of the research project, the machine doesn't belong to them, it belongs to Brandeis. They're part of a research project of the I-91 corridor. So the reason ACE Project is they're so close to they're so close, they got to, participate in this pilot. And Samba has been sharing this with all the syringe service program providers. And I will say we're, really anxious to be able to offer this as well. It kind of brings me to tears because we know how much this could help. And to hear the stories that Samba tells us, how much this is helping the people that they work with, it's just.
But it does suggest a model, so that, we certainly have sufficient institutions around the state that have these machines and the capacity to do the testing. So there might be something that could happen as a result of this pilot program that would allow for an MOU locally and expand what's happening, and including the training that you're talking
Well, I
about.
think this language that they're proposing that's in the other bills would
do that.
Would expand that and provide the immunity that's required, or the protections that are required. But my point in bringing up the pilot was there already is a pilot.
Yes.
And it's been successful in Vermont, and there haven't been issues with it. And there have been positive, not negative issues.
But you want to know the outcome of the pilot. And when does it end? You know what the date is for the ending of it?
I'm not sure the ending date on that, but I actually think I think that I'll reach out to Samba and see what data they have compiled so far. I know that they must have something.
That'd be great.
And ask if I can get that. I'll share it with the committee. And I just want to say, as far as the drug checking being available at syringe service programs specifically, I think the reason why that is so important is we've already built the trusting relationships with people who use drugs, and it's so hard to send them off to somewhere else to have that test done. And Samba has shared with me as well that getting the MOUs with the different law enforcement, they were able to do in Brattleboro and Bennington, but it was a challenge. And though it is a protection of sorts, he also, ACE Project, as we move forward, would also support the language in S119. They would feel more comfortable and safe with that as well.
Okay, Senator Weeks, you had a question?
I do. What got my attention was the alert sharing. And I don't want to slow down the bill, but I'm very curious about the alert sharing, because I think that's a huge part of this whole mechanism that could potentially benefit from some enhancement.
Wait, what sharing?
Alert sharing. So
Alert sharing, is that what you said? Is that what you said?
yeah, so you come up with a positive, you come up with a sample which is dangerous.
And then it goes out.
It gets distributed to those who need to know that there's a.
Right, go ahead.
So anyway, my point is, again, not to affect the bill, but just to become more aware of what that is and how mature it is would be, I think, a benefit to the new members of the committee.
So
That's fine. I mean, that is actually, it's my understanding from what I've learned in the work I've been doing on this, is that that's a fairly standard practice with this kind of thing. And that, that if there is a problematic substance found or new substance found, that information is shared with all of the.
And I'd just be curious, a little background, again, not necessarily directly related to this bill, but.
No, I mean, I'm super supportive of this, but I also don't want it to slow down the bill.
Here's what I'm going to suggest. We have David Englander from the Department of Health, and he's listening in, and alert sharing is frequently done through Department of Health, perhaps public safety. So we'll hear from David Englander. Any other questions for Mr. Gardner? This has been this has been very good, very informative. Thank you.
Thank you.
Okay, so we're going to move on, and we'll move you from that seat, and we'll ask our folks from Department of Health.
Well, thank you again for the opportunity.
Thank you very much.
Good morning.
Good morning.
Madam Chair, I'm having a little trouble with the audio, so I'm not going to stream video, and I apologize. I think the committee knows that I look like a young Cary Grant, so I think that's probably enough for us to proceed.
Hang on a second, David. We're just turning your volume up a little in here.
Okay, and again, I apologize.
No, now you're good. This is great.
Okay, so for the record, my name is David Englander. I'm the Senior Policy and Legal Advisor at the Department of Health. I'm happy to start off where we left off with regard to alerts, and the chair is exactly right. That when there is a problematic batch, for lack of a better term, that's something that we would work with law enforcement and EMS on. We would there's times when we would send out an alert through a HAN, which is the Health Action Network, which is a communication that goes out to, it can be as many as about, I think the maximum is about 40,000 providers. It can be everything from doctors and nurses to EMS and other kinds of providers. It is important to note that in general, the department favors universal harm reduction strategies, such as assuming that if you have street heroin, assuming that it has, for instance, now xylazine, or previously assuming that it had fentanyl, and the testing of things like fentanyl when it came to the state, it quickly overwhelmed the supply in Vermont, which is why step one in harm prevention is to assume that that the source that you're using is tainted, and then step two is if you have test strips, and as Senator Hardy mentioned, we're trying to push out xylazine test strips in the near future, and of course we make fentanyl test strips available for free as well. So with that, Madam Chair, would you like me to sort of stop and do do you want me to walk through the bill section by section, or what's most helpful to the committee?
Well, I'm hoping that you'll have testimony on the sections and from the Department of Health. And I know we don't have anything from you in writing as yet, but so if you would go through and give us a sense of those sections that are currently problematic or that you think need improvement, and we could do that. We have some time to do that in about 40 minutes, so that's good.
Okay. So just starting at section 1, so the department, this is the inclusion of needle exchange disposal programs. This is something the department favors, generally speaking. This is something that we worked with in House Human Services, working closely with Representative Whitman and Chair Wood. It's a question of how do we do it. This is what the genesis of section 2 is, the department's offer to work with existing structures and communities to determine how do we have disposal where they're most going to be utilized. So we do have limited amounts of information in terms of the best possible spaces. There's a question of whether they should be at pharmacies, at libraries, on the street. So what we would like to do is take the time to work with communities to figure out how do we meet the community, how do we meet the needs of the people who need these most, and how do we place them in areas that will be best utilized. So the department supports section 1 and 2. I do have a small tweak, which is that the first line says that the health department will work with blueprints, the blueprint for health, accountable communities for health. I think it's not all communities have adopted ACHs. So it would actually be cleaner just to say, we'll work with the blueprint for health. That's not necessary, but it is more accurate. So
okay,
we would.
And are you going to send us this?
I'm happy to do that.
Okay, so we're not gonna remember it all. Not everyone has in front of them writing.
Sure, I know, I'm happy to do that. But in terms of, creating a forum and a structure for those conversations and reporting out to you in the House, the department is delighted to do that work.
Okay.
Section 3 is $150,000 from the Evidence-Based Education and Advertising Fund. This is the that Nolan Langwall walked you through the source of these funds. This is not something that the department requested. It is not part of the governor's budget. We actually don't know how much it's going to cost. So just please understand that this request did not come from the department. Similarly, with Section 3A, the rise in the fund free from 1.75 to 2.25, the department did not request this. There is at this time sufficient funds, sufficient monies in the fund to do the work that are authorized under the fund, which we can talk about in detail at some point if you wish. In fact, at the end of FY24, there'll be $2.8 million in unobligated funds in this special fund. So this is something that we don't see as necessary at this time, given the jobs we've been given, excuse me. Section 3B, again, this is the needle exchange piece. That's something that the department supports. Section 4, all these language changes are all things. This is modernization and some matters that Jessa Barnard spoke to. Some of these pieces in the next two sections, these are all things the department supports. Section 5, which is the drug paraphernalia, that's important just as a matter of clarity. This is making it clear that harm reduction supplies are not considered drug paraphernalia under the law. It's unclear that has a profound effect, but it certainly provides clarity. I mean, we sometimes get questions whether fentanyl strips are considered drug paraphernalia because theoretically they could be, except of course, the legislature has authorized the Department of Health to spend money on them. So thus we infer that they're not considered illegal, but eliminating that provision really does provide clarity and consistency with the message from the legislature that this is what they want the state doing. Section 6A is something that we would defer to DEVA on. Section 6B, this is what Jessa was talking about. The department supports these changes as well. It provides consistency and simplicity and places this is a highly detailed directive section. And it really is more appropriately left to rulemaking, and those rules are in place. And I'm happy to share those with the committee if that would be useful. 6C is something, again, we would something that we support. Again, just a language change. And I'm sorry I'm running through this so quickly. I'm happy to stop at any point, Madam Chair.
We'll speak up.
Okay. I'll say, so Section 7 and all the Section 8s, the department would defer to DEVA on all those questions. Or I say all those matters. Section 9 has to do with recovery housing, or excuse me, recovery residences. The department supports this. We also support, there's new added language on page 15, line 16. This is this was a provision that was added by the House, which is it gives a job to the Department of Health to approve an organization. And that's something that the department is willing to do, to provide some nexus between the state and the National Alliance for Recovery Residences. And also, to be clear, we also support the substantive provisions of this section as well. And I think Section 10, the department does not object to this. And we fully support the effective dates in section 11.
That's okay?
Yeah, that 100, yes, fully endorse.
Okay, then in terms of the conversation, we'll circle back, but any questions at this point? Because I want to go back to the question that we were talking about earlier. So any questions about other than that at this point? Okay, so it sounds like with some tweaks, we'll get your testimony in writing, and that is very helpful. And you've also the insurance question is probably not for you, but the other question regarding S219 and the other bill that's in the House is a question for you in terms of what's happening with the pilot program and the testing of drugs out in the community. And so are you able at this time to give us some further information? I know you started out with it, but just offer clarity.
I am not able to offer any information this time, but I'm happy to come back to the committee when I have answers.
Okay, let's do that. We'll have you come back, and I know that there are questions for you. So Senator Hardy.
Thanks, Madam Chair. So David, you and I worked closely together on the opioid settlement advisory committee. And, you know, as I've made clear to almost everybody, and certainly the chair, I've talked to several times about attaching the funding forward quickly. I had conversations with you and the commissioner, and the memo that Dr. Levine sent as the chair of that group was from March 10th, and it includes $7.3 million in opioid settlement funds. And I very much like that to be included in this bill. I've sent it multiple times to people.
I got a copy of that. I didn't get a copy of the 219 stuff. I don't know, maybe.
The 219 stuff is something separate.
Yeah, I understand.
So this is the.
We have the commissioner's memo.
Right.
We'll put that up on our webpage.
Yeah, I sent it to, I've sent it multiple times to people. So Katie and Nolan and Alex all have it, but I'm hoping that David could speak to this and also just wanting to get this through quicker than the budget, particularly if the budget might be held up for whatever reason. You know, this is harm reduction, life-saving purposes, and it's not general fund, but we should move it along as quickly as possible.
I think the point you're making is really important, and perhaps David, you could respond to what Senator Hardy is saying. This is not general fund. It may or may not, it could be in the budget, but it isn't general fund. It comes from very special fund with very discrete guidelines for use. So is there any problem that you, from your shop, in including that money in the bill as we pass it out of committee?
So needless to say, the department strongly supports this proposal. The complexity actually doesn't come from the Department of Health. It comes from the requirement within the existing law that that requires that funds expended be subject to the annual budget process. And Senator Hardy and Representative Whitman and I have worked on a possible tweak that would speed that process. So the department supports these, period. The question as to whether or not this bill could be an adequate vehicle that meets the statutory criteria really would be for the parliamentarian or whomever within Ledge Council to determine whether that was appropriate. But the department strongly supports the expenditure of these funds from this source.
Right. Thank you, David, for that reminder about the tweak on the language. I mean, it does specifically say the budget, but I think that we can work.
Yeah, I mean, budget process for us means that it goes to appropriations and that they identify it as an expenditure. So I will I'll clarify that with Ledge Council and with the chair of appropriations ASAP, because this, you know, I agree with Senator Hardy completely on this, as well as with the advisory committee. The sooner we get this money flowing, the quicker we begin to have an effect, so.
Yeah, and so folks in the room, so this money is literally in the bank today. So as soon as we have authorization, we can start spending it.
Yeah, the sooner we can make it happen, the better off we are.
Yeah.
Yes.
All right. So
Thank you, David. I really appreciate it. I just want to make sure we save as many lives as we can.
For the record, I'm in favor of acting quickly as well.
That's good.
So I definitely think the drug checking stuff is worth talking about more.
Yeah.
I also just don't want it to hold up the rest of this
No,
stuff.
yeah,
And we have other
yeah.
vehicles that we could do it in.
We have an outstanding issue with Blue Cross and Blue Shield and VMS. They're gonna get back to us with something. We'll go through the bill again together, looking at the language, and we'll have the discussion about how and whether and what we might put in regarding the checking, testing stuff. So, and we'll do that. I think we have it up for next week. I don't have next week in my head right now. So,
Tuesday?
no, so we'll,
Because it does have to go to a probes. And the chair of that committee is in the loop as well.
I understand.
Okay.
We're not ignorant over here.
I know that. I'm just trying
Yeah,
to
it happened. Oh my
act with
God.
urgency
Look at your
here.
wishes granted. I
Thank
do have it
you.
up on Tuesday. This is an important bill. There's no question about it. As is 171, as is 206, as is some of the others, but this one, we've got money. We may as well start spending.
Yeah.
So we're with you. Okay, so we're gonna take a break right now and we're going to come back in 20 minutes. So we'll come back just before 1:15.